Thanks very much for having me. My name is Ross Mitchell, and I'm the last author on this paper. The first author is my grad student, Wenji Zhu, who's sitting right there. Wenji, you want to put your hand up? So he's the guy who did all the work. I'm just talking about it. Mayo Clinic, in case you're not aware, and I apologize for those of you who had to watch this morning, largest private not-for-profit group medical practice in the world. We treated 1.3 million individual patients last year from 135 countries from around the world. 120 million Americans are in network. We're 150 years old this year, and we're proud to have been recognized as the best hospital in the USA from US News and World Report for the current year. I'm here to talk today about cancer and some of the work that we're doing in the radiology department in Scottsdale, Arizona related to this. We're primarily interested in clinical trials of new therapies. We all are aware that cancer is a bad disease, 1.67 million cases a year in the US and over 500,000 deaths a year. We may not realize, a lot of us may not realize the enormous cost required to develop a new drug. It's been estimated recently that it's approximately $5 billion to develop a new drug. And 90% of this cost is spent in the large phase 3 clinical trial. There's 3 general phases. The first one, phase 1, is to do no harm, evaluate toxicity. Phase 2 is dosing and treatment regimens, and those are usually done at a single site with less than 100 patients. And the phase 3s are big, multi-site that could have thousands of patients and take years. So it's sort of understandable how the cost goes up from phase to phase. You may also not realize that approximately 3/4 of these big, massive, expensive phase 3 clinical trials fail to prove efficacy and fail to garner new drug approvals from the FDA. And a lot of this is blamed on poor phase 2 endpoints. We have surrogate markers for effectiveness in the phase 2 trials. It turns out that the most common method of measuring response is an algorithm called RECIST, Response Evaluation Criteria in Solid Tumors. It was most recently updated in 2009, and this is a radiological evaluation of change in medical images of the patient as they undergo treatment. Basically, they ask a radiologist or a substitute, but the final measurement is always reviewed by a radiologist, to measure lesion volumes over time. And you can imagine that if they see the lesion shrink, the presumption is that the drug is working, whereas if the lesion gets bigger over time, the presumption is that the drug is not working. It's pretty simple. The problem is how the measurement is made. This is an MRI of a patient. It's a cross-sectional image called an axial image taken in a stack down this way, and it's up here above the level of the eyes. And the white puffy area in the top left is abnormal. In the brain, you like to see symmetry on each side. And you can see that there's a more intense white area. That's the cerebrospinal fluid ventricles in the middle bottom. That's normal, it's symmetrical. But in the top left, there's this puffy white area. That's a large brain tumor. And this brain tumor is very aggressive, this particular type of brain tumor. Without treatment, average expectancy is about 11 months from diagnosis. And with the best available and most aggressive treatment that we have, we've managed to extend that life expectancy to about 30 months. And that's 30 years of research. That's all we've been able to accomplish in brain cancer. It's pretty depressing. So there's an outline of the lesion, and this is just in one slice. It'll exist in slices above and below that in 3 dimensions. And so the goal of the radiologist is to report the volume of that thing. And what they do is they scroll through the stack of slices until they find the one with the apparent largest cross-sectional extent. Let's assume that's this slice. Then they eyeball the lesion and they draw a single linear diameter that spans the largest extent of the lesion in that one slice. And that's the recorded measurement for volume. It's not even a volume measurement. They'll report a measurement in centimeters, not cubic centimeters, centimeters. So this might be 6 centimeters, let's say. And that will be put in the report. And you can imagine the patient getting treated, coming back in a couple of months, and this thing looks quite different. And they maybe scroll to a different slice and draw a different line, and now the measurement is 5.5 centimeters. Has that grown or has it shrunk? Technically, you can do this in multiple lesions. In a case like this, you'd probably only do the one, but in other organs and other cancers, you can bring in lymph nodes, you can, it gets very complicated. But basically, it comes down to drawing the largest diameter in one or more lesions. So this isn't very sensitive to change, as you can imagine. So this is the part of the algorithm. You have to see this measurement change significantly in order to infer a change. It has to grow by 20%. The sum of these diameters has to grow by 20% to call it progressive disease. The drug is not working. And it has to shrink by 30% from its max or min over time to say that the drug is working and there's some sort of response. You got a 50% range there where we just don't know what's happening. And in a lot of cancers, it may take weeks, months, or even a year or more before you get enough change in the lesion one way or the other. And by that time, it's often too late to swap to another therapy. So why is it still so popular? Well, basically it's fast. It only takes a few minutes to do, and that's critical in the busy clinical workflow. It's conceptually simple. Just draw a line. And it's broadly useful. You can use it in any imaging modality, any lesion, or any organ. So our work is driven by the belief, hypothesis, if you will, that to supplant this in clinical practice, not in research, but in clinical practice, we have to have all those criteria. It has to be fast, conceptually simple, and broadly useful, but it also has to be more accurate and reliable. And that's our goal. So to address this, we're turning to an algorithm that's been studied quite extensively for the past 15 to 20 years. It's an evolving surface algorithm called a level set. And basically, a lot of prior research has shown that this is very robust. It's accurate and highly reliable, and that's why we turn to it. And the way it works is you place a seed inside the lesion. Let's call it this green circle. And then this evolves over time to hopefully merge to a covering of the object that you're interested in. And this is driven by several things. It's driven by the intensities, but it also has surface tension. And you can think of this is like inflating a balloon, and the image intensities tell the balloon where to grow, and the surface tension controls the size of the crevices that it can grow into. The problem with the level set is that it's not rapid. You're calculating a partial differential equation at each point along this surface for many thousands of iterations. The steps have to be small for this to converge. And it's not simple. It's not conceptually simple. Often you're presented with a calculus equation, and a physician is expected to fill in some parameters. It's just not going to work. And so that's limited to broad utility. So we want to tackle the latter two of these, speed and simplicity. So to get speed, a previous graduate student of mine figured out how to get this to run in a new way on graphics cards. This was developed in CUDA, and here we're loading a couple of image volumes onto the card, and we're getting a green blob out. That's the lesion in this case. We've published a fair number of studies now showing that this is accurate and reliable when we measure known objects and in patient studies as well, comparing to manual outlining by an expert, which is laborious but quite reliable. Importantly, we also showed that this is 14 times faster than the best parallel algorithms that currently exist. It's hundreds of times faster than the best serial algorithms. So a 14-fold improvement is what you might expect by going to the GPU. We got that on the GPU from the previous best algorithm. This paper cited at the bottom also includes a proof that this algorithm is both work and step efficient, which means that it will scale well with new parallel resources and does no more work than the best serial algorithm. So it's optimal in that sense. So what's it look like? Here it is. The user draws a green line in what they want and a red line in what they don't want. So here we want the brain, we don't want the ventricles in the middle. This is a real patient data. This patient has mild cognitive impairment, part of the Alzheimer's clinic. And you scroll through the stack of slices, and it doesn't matter. It's not so much sensitive to where you put the strokes. You want to put them in the right tissue, the tissue that you're interested in. Up here you can see all kinds of little pock marks in the brain. That's due to the dementia or causing the dementia. So after we've drawn a few strokes, because it's running on the GPU, you can visualize it. So this is just a maximum intensity rendering, but you can see the strokes in 3D. A lot of that stuff, we don't need those parameters. There's basically just one parameter. And when we click go, it's going to think for a second. And it's going to grow the brain. And it only takes a few seconds. And the level set is still running while we're looking at it. So now we can go up and interactively adjust that surface tension parameter. And by lowering it, we can let it leak out. And by raising it, it encourages a smoother, smaller surface. So this is the first time that people have been able to interactively explore the parameter space of this complicated algorithm. And when you tip it back over on its side and scroll through it, you can see all kinds of interesting things. First of all, it's done a good job of segmenting the brain. There are no holes in the green tissue. It handles the noise very well. It hasn't leaked. So overall, quite a nice result for this. So how does it work? Well, as you saw, the user places strokes in what they want, green, and what they don't want in red. And we use this to train a classifier to derive a function that drives the evolution of the surface of the level set. It's actually not that much Python code. And how it works in a little bit more detail, we have typically multiple medical images that are co-registered, show the same scene and are spatially aligned. And we use information from all of them. So in this example, there's 2 different kinds of MRIs of the same brain. And let's say the user has drawn these strokes, green and red, for desired and undesired. The first thing is to realize that these intensities are actually features in a machine learning problem or a classification problem. So what we're trying to do is fill in this feature space, a 2-dimensional histogram. And the vertical axis corresponds to intensities from dark to white in the top image, and the horizontal axis is the same in the bottom image. And if we look at a single voxel here in both images, in the top image it's kind of bright. Let's say it has an intensity of 210. That tells us where to index on this axis. In the bottom image it's a little darker. Let's say it's 45. Tells us where to index on this axis. And then we just increment that location. And after we've processed all the voxels in that stroke, we'll end up with a cluster of some sort. And we do the same thing for the red stroke and end up with a second cluster, and then we apply cluster classification algorithms. And the contours in this indicate distance to the various clusters. This is a k-nearest neighbor clustering algorithm, but in theory you could use anything. The next step is to normalize these distances onto the range -1 to +1, and this converts this into a speed function that we can use in the level set. Here, positive values in green encourage faster growth of the level set, and lower values in red encourage faster shrinking of the level set. Here's the speed function tipped on its side and looked at in 3D. The next key thing is to realize that we can bake this in. We can construct an image like this that shows the speed function, and then we don't even need to put the images on the GPU. We can get rid of those altogether and replace them with the speed function. And this has a number of advantages. It greatly simplifies and accelerates the code. We don't need to change the code anymore if we change the number of images for a particular problem. It will make it easier for others to leverage our GPU level set. They don't have to write CUDA code. They can just bake their experiment into the speed function, and we hope it'll help us simplify porting this to other non-CUDA platforms. So with the time I've got left, I'm going to just show some demos. This is a liver segment. This is a liver tumor. So that's the liver, and the sort of gray area, dark area is the lesion inside the top of the liver there. So just drawing a few quick strokes. Tip this on its side. You can see the spine, the ribs, and the kidneys there. And when we click grow, it goes off and does the classification. This has got multiple contrasts associated with it. And you can see that's a complex object. How could you characterize that with a single line? And scrolling through it, you can see it's done a pretty decent job. And we know the volume of that. We can click on a button and get the volume. It shows us the volume there, 34 mils. This is brain vasculature. We've already placed the seeds, and when we click grow it, you can see it go off. This is a contrast-enhanced CT scan, and it's finding the brain vasculature. This patient has an aneurysm at the top of the basilar artery, and this is a very deadly condition. This is being used for treatment planning, simulating the placement of coils in the aneurysm. So you can see as we lower the surface tension, it grows out and grabs smaller and smaller vessels. So the surface tension is limiting what it's growing into. Then we might typically mesh this and export it into a flow sim package with collaborators at Arizona State University, and they can do all kinds of cool things once they've got a mesh on this. And we can also use it to segment solid organs. This is a kidney. What we want is the stuff, the bright stuff, and what we don't want is inside and outside. Just a couple of strokes. And we're testing this now with segmenting the whole liver. We've just recently tried it with the spleen. We've done vascular trees, and I'll just let that go as we finish up, and happy to take any questions. You'll see it segment the one here and we're going to go off and segment the other kidney. This is of use in transplant studies for a donor, where they're looking for the larger kidney to put into the receiving patient. So they need to know the volume of the two kidneys. Anyways, that's basically it. It's the rule of thumb is if you can see it or if it's got some contrast, this probably has a good chance of segmenting it. And the more high resolution and more complex the object, the better this works. It's sort of the opposite of how humans do things. Thank you very much. Yes.
So how does it seems like you don't have to draw very many strokes, and yet it still figures out, the actual volume very accurately. How does it do that? Maybe it's just magic of machine learning. It seems like a complicated shape for such a few strokes.
Yeah, I showed the brain initially, very, very complicated shape. And we can segment the white matter independently of the gray matter, and the white matter is even more convoluted surface than the gray matter, the whole brain is. So that's the magic of the level set, really. It grows, it's indexing into that speed function, and it says to itself, should I include that next voxel or not? And it does, but then the next iteration, it has the option to back out again. It's not a firm commit. Eventually, as things settle down spatially or over time, we cull them from the active set. We say, okay, that's basically carved in stone, we're leaving it, and the surface evolves outward. If you placed the seed incorrectly, like say you said, I don't want ventricle, but part of your seed was in the ventricle, what it'll actually do is shrink out of the ventricle and grow around it. It's pretty cool. So that's, that's the level set algorithm. That's the 15 plus years of research driving this to be a very robust algorithm. This particular implementation is very simple, and that's intentional so that all the brains goes into the clustering and the speed function, and then we just take it and make it really run fast on the GPU. Yes?
Is this available?
We'd like to make it available. Yes, we'd very much like to make it available. I would like to, this is all written in Qt, and first thing we'd like to do is make it so that you can just write a simple Python script to generate the speed function, and you can use it for whatever. I mean, not even non-medical data. The geophysics folks could use this to segment rocks and things, whatever. We'd really like to get it out there, so we're thinking about how to do that, definitely. And the other thing we'd like to do, I hinted at the end, it runs on CUDA right now, and that requires essentially Windows and an NVIDIA graphics card. We'd like to port this to either OpenCL or Apple's new Metal API, so it'll run on Mac and Linux as well. We really need to be down on the metal to get the performance. So, but we want to abstract that away from the user, both in terms of, like a year ago, we were writing CUDA code every time we wanted to fiddle with the algorithm, and now we don't have to do that anymore. We just generate a new speed function. It's really cool. Yeah. Sorry. You just draw something and it works. It's much more sensitive to the surface curvature. As you can imagine, adjusting that causes it to shrink, and a little shrink, that surface integral is a large volume. So most of our research has been on how do we optimize that surface curvature. But the strokes, basically in a fuzzy connectedness problem, if A is connected to B, it's a good chance B is connected to A, so it doesn't matter where the seeds go. Thank you.